Hi, it's Dr. Dave McCreary from POCUS UK, and this is a video showing a case of retrocecal appendicitis in a child. So when I'm scanning for appendicitis, I'll use the high-frequency probe and either ask the patient to identify the site they're most tender, or I would tend to check down for the iliac vessels, and if not, I will look around as I'm doing here, and that normally does the job. If it doesn't, maybe the appendix is hiding in one of the common positions that it can do, either retrocecal or pelvic, as shown by this image. And the data underpinning this was significant. In the 1900s, 10,000 surgical cases identified retrocecal as the most common position, in addition to some more recent surgical studies. So even this 2D cartoon demonstrates how tricky it can be based on the different positions the appendix can project, either deep or posteriorly, or of course laterally and medially. And there was this nice paper by Chang et al. That was a mixed adults and pediatric study where they scanned initially with patients supine and then rolled them onto the left posterior oblique position and then scanned again. And this demonstrated, as you can see from the graph, that their visualization rates improved massively and CT rates went down. And their theory was that a lot of the appendixes in their study were in fact retrocecal, as shown in this image. Here's a CT showing an appendicular abscess in the retrocecal position. We can see that scanning from this initial position would take use of the musculature as a sonographic window, as opposed to the second ultrasound probe, whereby we're going to be scanning through the cecum with a gas, causing our ultrasound beams to deflect and not be transmitted well, meaning we might miss out on an appendix that's positioned there. Here's the normal position, showing the blind ending loop just below the ilium, which I've marked in yellow. I've got the 5 layers of the appendix wall. And this is fine if we're in this position, very, very superficial. But actually, in other cases, what we might see is that we're in a much more tricky spot. So this was the patient I had, and his family were excellent and allowed us to use this video for educational purposes. He had pain in a very unusual place, pointing just there above the iliac crest with a red star. And excuse the poor images, we're getting this in real time on our mobile phone just to show, as we're scanning, the appearances that we found in this unusual position with the patient turned onto the left. We can see there we've got increased colour Doppler pickup, significant inflammatory fat wrapping, as you can see here on the proper image. And visualising this anteriorly with a patient supine, we just couldn't identify this. Here with a curvilinear probe, see this all hyperinflammatory fat wrapping deep, mixed in with the gas even in this position, quite tricky to pick it up. But actually you can see there centrally we've got a fecalith, an appendicolith, and everything's extremely hyperinflammatory and echogenic. So the appendix measured 1.3 across. Here's another example of a retrocecal normal appendix. See the polar mint sign with the lymph node next to it. And again, here's another example of a normally positioned appendix, very superficial and anterior, coming across with this blind ending loop. Another example, and then an arrow denoting that blind end. So just as a recap, some of the features of appendicitis that we might look for, people I'm sure are very familiar. So here is an example of really significant echogenic wrapping with enhanced colour Doppler appearances. Here we've got some really thickened walls, very, very echogenic surrounding the appendix, seen here in transverse, with adjacent bowel loops next to it. We can obviously never mistake an inflamed appendix for a standard loop of bowel. There's absolutely no peristalsis, and we've got very, very thickened walls. Here we can see again another appendicolith centrally. And in some cases, it's extremely echogenic, meaning we have to adjust our gain in order to be able to make sense of what we're actually seeing. Laterally, we're seeing examples there of a perforation whereby the wall architecture is completely lost, and we're likely to have localized regions of free fluid, which we have there. I hope that video has been useful, showing you how to position a patient to scan for retrocecal appendicitis.